Chicagoland, the 11th annual Chicagoland 5K SCAD research. My name is Ellen Robin, and I am an almost 15-year survivor. And I am the president of SCAD Research, Inc. And I'd like to again welcome everybody. And welcome to everybody around the world. We have people online that are all over the world, so it's exciting. I'd like to thank Nick over there that is manning our video live streaming. If it weren't for him, we'd be just talking into a little hand mic and using a Facebook phone and it being upside down the way I did it once. So, also, I would like to thank Tara. Tara is a sister of a SCAD survivor, and she put this whole event together, the whole weekend. Trust me when I say it's a lot of work, it's a lot of work. I know personally, so thank you so much for doing this. It's wonderful. Also, what I'd like to talk to is just give you a quick update on SCAD Research, Inc. The board of directors, we meet on a monthly basis, and we have, over the last year, we've been trying to make some changes, and one of the things that you should see coming within the next year is a brand new web page for SCAD Research Inc. We're working on that. We are working on education. There should be some events coming down the line that involve education of SCAD Research Inc. that you'll all be able to be involved in. And one of the other things is that we're doing is we are spreading it around to have a lot of helpers. We're so grateful that Bob and his family ran the board for many, many years. They did a lot of it themselves. And I know that we need help. And so we have new committees that are being formed. And for those of you that have volunteered to be on a committee, you should be in touch with somebody from one of the board of directors. Very soon we are starting to create our committees. We'll have a fundraising committee. We're going to have a education committee and a marketing committee. So again, if anybody's here wants to volunteer, it doesn't matter where you live, because we'll do everything by Zoom. And I also want to let you know is that since 2012, SCAD Research Inc. has donated over $1.45 million. And that doesn't include this year, and hopefully we'll get over 1.5. But it would be nice to do more. And the majority of the money that we've donated has gone to the Mayo Clinic, and we're very grateful for the research that Mayo has done. They were the first organization to start a research, a registry, and now if you go online, there's a lot of things being done. And it's because of what started from SCAD Research Inc. donating money to the Mayo Clinic and the Mayo Clinic doing the work. And so I can tell you personally, from when I had my SCAD almost 15 years ago, there's so much more known. Nobody knew what it was when I had mine. Now, I mean, there's still a lot of work we got to do, but there's a lot more people know about it. And so we're very grateful for that. So that being said, I'm going to introduce Dr. Hayes and Dr. Tweet here from the Mayo Clinic. They're going to be giving you a presentation on the latest and the greatest on the research. Dr. Hayes is a cardiologist and professor of cardiovascular medicine. She has over 25 years of experience in treating complex heart and blood vessel conditions in the Women's Heart Clinic. Dr. Hayes is also the clinical lead research for SCAD, which we're very grateful for. And then Dr. Tweet is an associate professor in the Department of Cardiology at Mayo Clinic. And Dr. Tweet has been with the research since the beginning. And Dr. Hayes and Dr. Tweet were the beginning of the research. And so we're going to bring them both up and let them talk to you.
because Dr. Tweet and I started this research sparked by some ideas back in 2009, late 2009. We really didn't, we had to noodle on it because both of us had been taught that this was so rare that we would not be able to study it. Like maybe I would see 1 or 2 in my career, and I saw 6 yesterday. So a lot has changed, but the thing that really hasn't changed is the support and the partnership with SCAD Research Inc. and with patients who are supporting our research. I'm just going to say, because we're going to tell you a little bit about research, but one of the things that I didn't really know, because I wasn't a deep researcher, but I was told by my study coordinator, it's currently Sue Milbrandt, who some of you may have interacted with, is, wow, Dr. Hayes, I'm a study coordinator on 2 other studies, and we're just like having to beg for people to be a part of it. And your SCAD patients, they're just like calling us all the time because they so want to be a part of this and to advance the science. And that has really been one of the things that has been a signature in many ways. And so that's why we show up, and that's why we keep doing what we're doing, because it's not just that we're SCAD nerds. I mean, we kind of are now. I mean, I'll own the term, because we think there's so much to learn and we want to learn it. But we are buoyed by the fact that there are a lot of folks like you who are, and those who are online tonight, who are pushing us forward, who are counting on us, and we do not take that lightly. And so tonight we thought we would share a little bit. We also know that some people are new to our presentations, and we don't want to take for, are we too close to each other or something? We don't want to take for granted, so we'll do a little basics on SCAD as well for those of you who may be kind of new to it. So this should work. It was working earlier. And if not, we'll advance it. All right. So that's a t-shirt. I just took a picture of the back of my t-shirt, actually. Yeah, there we go. So I just said that, but yes, we are very gratified. And the photo up there is actually when SCAD Research Inc. reached a threshold of giving Mayo Clinic $1 million. They get a plaque on the wall, and not just from Minnesota. So, and we had some folks there on that event. And many of you, some of you don't know Bob, most of you probably do, but Bob was featured in our alumni magazine because of him starting this organization and our partnership, and Bob has become a dear friend as he has advocated, given thousands and thousands of hours to make sure that those of you who have had a SCAD know more about SCAD, and keeps us honest. And we do have fun when we come. With some old pictures and the whole tweet plan there, as you can see. Yeah. And they'll be there tomorrow, but they've grown up. So just a little background. Why is it significant? I sometimes tell patients, I say, the science of SCAD is still pretty young. We've been studying certain things for decades, and really there was a paradigm shift on how we viewed what SCAD was around 2011, 2012. There were publications from Mayo, but also from some other investigators who were observing, hey, this isn't as rare as we were told when we went to cardiology school. So if you look at this, for 50 years, it was described as a rare or extremely rare. It was survivable, would be, if somebody survived a SCAD, you could write up a paper and get it published. Right? That's what they thought. It was like most people died, and a lot of the literature was in the pathology. And so there really wasn't much, and I think I can characterize this slide by saying it was misunderstood, it was grossly underdiagnosed because of the criteria that we'd all been taught, and that's kind of how it was. And I used to say that SCAD was a paragraph in my cardiology textbook, and then I was actually giving a talk at a big meeting, and I said, well, I'm going to go back, because I have an office at home, and I found that cardiology textbook. It was not a paragraph, it was like a sentence. So this is the when I was a cardiology fellow and a young cardiologist, that's what SCAD was. It was was listed one other place in a very long list of about 80 things that can cause a heart attack. So, what's changed? Well, you guys have gotten us to do things. We are collaborating not just among ourselves with radiologists and endocrinologists and cardiologists and geneticists, but across the world with other people who are studying this. There's a lot of committed people out there. We've got new hypotheses. The registry that many of you have participated in at Mayo or perhaps in others gives us insights that may not be the be-all, end-all or the answers, but tells us how can we take it, and you'll hear later as we talk about this, some of the things that Dr. Tweed is doing that is like, okay, here's some things that made us ask some more questions. What are we going to do to answer those questions? So, we're looking for evidence. We've, I think, partly because of the great team that we have, but also the funding that we've received from SCAD Research, some of the big studies and the big statements about SCAD have been heavily represented by Mayo. I'll let you talk about this one because this was our first.
Yes, and this is just an example of describing how this all became to be. And I think, Sharon has shared this story many times, but patients approached her asking what Mayo was doing for research, and then she engaged me, who was an internal medicine resident at that time, not even sure if I was going to go into cardiology yet, and she drew me in. Not only that, I ended up staying at Mayo for cardiovascular fellowship after internal medicine residency, and then I ended up pretty much crafting my career to study SCAD and care for SCAD patients. And so this poster kind of describes those beginnings when I remember our first study, just to see if our registry would work, was 12 patients, because I went to a seminar that said pilot studies, a good number is 12. So we talked, and I said, let's do 12 patients and see if it's possible. And sure enough, it was. And then I just remember with the Institutional Review Board, to get approval to do this in an ethical manner, we kept having to increase the total number of patients we were intending to study, because I think we started out a really low number, thinking we would be lucky if we reached that number, and then it just kept growing, and we'd have to update, and then it kept growing, and it became, a whole topic in of itself.
Back in 2011, 2012, because of this history which we just showed, we thought if we were able to get 100 patients in our registry, wow, that would be the biggest registry that had ever been published. And we now have over 1,600. And it was one of those things where each time, we'd have to say, oh, we have to revise our application for that. So this is a little of history we talked about, but this is sort of the timeline. That 12 patients was published in 2011.
Those 87 patients was the largest series in 2012, and it was published in Circulation, which is a very respected journal in cardiology. But at that time, the other series were less than 30 patients.
Yes. I think, interestingly, one of the reasons that research works at Mayo, one, we're a very collaborative group, that's a part of our culture, but that 87, that had actually, so Dr. Tweed and I were doing our own prospective registry, and then we found out that our colleague Dr. Galati and another fellow who had just left Mayo were trying to understand these 87 retrospective, and so Dr. Tweed picked up the mantle because of the other resident. And so it really was like we're all sort of seeing this as an important thing. So the registry, and they're not here, but Dr. Best, Patricia Best, she's an interventionist, Dr. Rajiv Galati, and then a whole host of other folks who are working on this. They're particularly important, and if you've ever been part of our study and had some delays, it's because they read every single angiogram that someone thinks might be SCAD for our SCAD patients. Officially, we read them too if they're our patients, but they're the ones who really have read thousands of them, and they don't get any specific time to do that, so sometimes they batch them all once a month. It's not like they do that a little bit every day, but they're super important. And we continue to collect surveys, and you may just see a survey this summer if you were part of it. I think the other thing, PubMed is where they publish, this is just another indication. So if you look back from the 70s to 2011, remember our first there were hardly any publications per year about SCAD. And if you just look at the trajectory through 2023, so it's not just us, those are not all our publications. That's just the fact that if you put it on the map and people are starting to look and say, I think I saw that too, I'm gonna study this part of it. And it's good for all of us. So that's Dr. Best on the left. And we've updated our website too, so if you haven't been there for a while, please check it out. So, what are we doing? I think that's important. What do we do with the funds that we get and those that we seek from the federal government, from NIH? We're trying to increase knowledge. So, we design research studies, both from registries but prospective, and I'm going to let Dr. Tweet talk about that later. Then we present it, and for those of you who don't know what a poster is, you think, oh, a poster is what my teenager put together at homecoming, right? A poster is what we in medicine and many other scientific fields, it is a graphic and data-driven visual that may actually be a physical poster or now often just electronic that is shown at national meetings. It's peer-reviewed, and during the time that our poster is up or being discussed, people come around, they read it, they ask us about it. They say, hey, I'm studying that too, why don't we collaborate? So posters are an important first start in the scientific process because we publish it, it's not peer reviewed yet. We get some feedback and then when we actually publish it in a paper. So then we publish it in peer reviewed journals, we share it in social media, we engage many colleagues, and there's a number of folks who we have trained who are now doing SCAD work or certainly spreading the word, collaborating with others, and filling the knowledge gaps. So, bottom line, we're trying to improve care for all of you. And the peer-reviewed publications for academic medicine, for what people read or believe, that's when you submit your manuscript. I've done this study, here's my data, I'm going to write it up, and then a bunch of people that you don't know, the journal sends it out, and they poke holes in it, or they say, hey, this is really interesting, or you need to talk more about this. And then it gets published, and then that's how we spread the knowledge, because that's how we, if I'm learning about, not SCAD, but maybe I really need to know about a specific type of heart failure, I'm going to go to the peer-reviewed literature and learn more of that, and that's how they're learning about SCAD. I'll just let you talk about, these are some of the observational studies that...
Or you can page through them because I don't want to overwhelm our audience, but these are just examples of some of the papers that we've put out through the years on a variety of topics, engaging members from the team with specialties that are relevant to the topic being discussed. So really high quality work based on what we're doing in the clinic on a variety of topics. So one of the benefits of chatting with you all is also hearing what, both in clinic but coming to these walks, is hearing what's important to you and where you feel like there's a lack of knowledge. And clearly there's a lot that has been learned, but there is a lot yet to be learned. And some of the topics that we've focused on, or papers we have written, have come from individuals saying, well, are you doing this? Has anyone looked at that? I have this, is that related to SCAD? And it's very hypothesis generating, so I just have to say thank you to all of you because we listen. And when Sharon and I and others on the team are talking, we bring those topics up and say, how might we study this? Or this has been brought up by a number of patients. It might be something really important, like menstrual-related angina. And that will then causes us to look into it further. And many times some people come out on it where it's published. And then the next time another patient asks about it, we'll be like, well, we have a publication on this. Or if a physician says, well, I never heard of that, and then send them the link. And I'm like, well, it's documented, it's there.
So, just bottom line, those of you who are SCAD, this is a helpful graphic sometimes for those who don't understand the difference between, and so what you can see, that's a normal artery. That would be a SCAD. Both of these are SCAD. One is an intramural hematoma. That's where the tear or the bleed is in between layers of the artery. And there you can see there's actually a tear that is loose. Now, I think, and here's the cross-sectional, I think what's important is that this on an angiogram, you can see how this, if you were just looking at the lumen, and that could look very much the same. And so that's one of the challenges, is diagnosing it by coronary angiogram. A lot of challenges. One is the kind of people who come in having a SCAD often don't look like heart attack patients. So the first thing, thing to overcome is actually getting a workup and having a heart attack evaluated. And then even if they get to that point, we said this person is having a heart attack, taking it to the angiogram, having an angiogram, sometimes the angiograms are kind of tricky, even to Dr. Galati and Dr. Best. This is working, but it's just so it's not that. And I think it's important when we put that X over it, is you can tell that the difference between something that's a buildup of plaque, cholesterol, damage of an artery versus a tear, very different. This is really a bleeding event, SCAD is, if you think about it, it's a bleed between two layers. Whereas when somebody has a plaque rupture and a heart attack due to atherosclerosis, it's a clotting event. And I think that's one of the differentiations that we talk a lot to patients is, if you've got a bleeding event, you don't necessarily want to give a lot of blood thinners at that time. And that's one of the things that sort of come out of the research. So here's just some baseline knowledge. The average age is probably in the 40s, early 50s, depends on the study that you look at. It is about 90% women. In the past, the proportion of women was lower, in part because I think that they were over-diagnosing dissection in men and missing it in women. It's probably about 10 to 15% peripartum. If you look at old studies, it was more like 30 to 35 because those are the ones they were recognizing. So it's less about people who are pregnant, it being less risky. It's that we're recognizing all of the other ones. It's not as rare. As I said earlier, we weren't diagnosing it properly on the angiogram. The biases that we have, not even doing an angiogram. And what we think is probably SCAD makes up somewhere between 1% and 4% of all heart attacks. I think it's important. It's often important after one of these presentations because somebody will say, well, I heard about SCAD. I've been having these symptoms for a year. Do I have SCAD? And I think it's important. SCAD is a tear, an event, and about 98% of the time it is a heart attack. There are a few cases that are rarely, but I think we can reassure somebody who's been having lots of problems. It has the same symptoms as a heart attack. Anything to add on this? And I think one of the big things we learned, and it came out of the study that was the 87 back in 2012, is that the complication rate, if we go in and do the typical heart attack treatment, i.e. putting a stent in the middle of a heart attack, is there's more complications related to that. It's a harder procedure, and many of these arteries will heal on their own. So that's actually been one of those paradigm shifts where instead of rushing in and putting a stent in right away, is more often we'll say, hey, this is a SCAD, let's see if this will heal on its own. Doesn't always. This is a study that Dr. Tweet really led that looked at, okay, people were saying, oh, women, they have weird symptoms. They have unusual symptoms. But what we found was the vast majority of people who have a SCAD, they have heart attack symptoms. They have chest pain. They have symptoms of some type. All of these are on the list. If you go on the American Heart Association, the symptoms are heart attack. I think the other thing that was concerning for us is that troponin test that we recommend that everyone gets if you suspect a heart attack. It's a very sensitive enzyme test that says there's been heart muscle damage. About 20% of women and men who come in, their first troponin is normal. So they're 35 years old and they have a normal troponin even though they've had chest discomfort. We worry about that because there is increasingly looking at saying, hey, if somebody has a normal troponin, we should just, and low risk otherwise, we should send them out. And this was a caution. And it may be that women who are having a SCAD, they're very in tune to their bodies and they know something's wrong. So it's even before the troponin has had a chance to rise.
Yeah, Dr. Hayes, I just wanted to mention too, you and I both worked closely with Dr. Alexis Johnson. And she started doing SCAD research with us when she was a Mayo medical student. Now she is on the West Coast practicing emergency medicine. And so, as you can imagine, she is very knowledgeable about SCAD. And so one of the reasons why I love working at Mayo Clinic is we are constantly interacting with trainees, and we have them shadowing us in clinic or doing projects with us. And that is just another way of disseminating the knowledge. And the first responders, people in the ER or other specialties, will actually then have in-depth knowledge about SCAD as a result. And then they share that information with their colleagues.
Exactly. And we love working with medical students and trainees. And, we feel like even if they don't go into cardiology, like we've grabbed them a little bit and they'll spread it, whether they're OB-GYN or emergency medicine or whatever.
Or urology.
Or urology. Recently, I actually, she did a big study on this. I think we need more women in urology too, so I'm just saying, it was a woman medical student. I think it's important. I don't know if we have men with SCAD here tonight, but they are often forgotten. I spent my entire career talking about how women are underrepresented in clinical trials. And here we have this thing that I'm studying the most, where there's very few men. And so if we think we don't know enough about women with SCAD, we really don't. We know even less about men who have a SCAD, because they make up only about 10%. And there do appear to be some differences. They are, on average, younger. They are more likely to have a reported trigger of exercise rather than emotional stress. Now, perhaps that is more that men may be more physically active. I don't know if it's actually that that's the case. They're less likely to have migraines and fibromuscular dysplasia or arterial abnormalities when we look at them. They're less likely to have a lot of problems with chest pain post-SCAD, which we estimate happens in about 40 to 50% of women. But in terms of their long-term outlook, it's about the same as women, and that's what we tell them. We have a number of men in our practice. Another thing we need to talk about is SCAD can recur. You've heard that as we were introduced tonight, that some people have had more than one SCAD. We are working very hard, looking at our data, trying to look at our data set to help add to that. If we look at all of the different studies that are published, and they all have different methods, and they have different numbers. But if you really compare them and read them carefully, it's about 2 to 3% per year. So it's not very likely that somebody's going to have a recurrent SCAD, but it happens. So what I tell patients is, you have to live your life like it's not going to happen, but be prepared, have a plan, if it does. You're, instead of sitting at home or going to urgent care, maybe you call 911 and go straight to the ED this time. Okay? I think the other thing is, I think there was a belief that, if we put a stent in, we do a bypass, somehow that would prevent a future SCAD, and that's not the case, because actually a SCAD typically is in a different artery than if there is a second one. Is there anything else you wanted to add? No. So, just baseline, these are some of the things that we have learned. Some of them are in consensus statements, some of them are more an abundance of caution because of things we know about SCAD. In general, many of you may have been told, you should be on a beta blocker like metoprolol, or you have to be on a beta blocker. I will say that the evidence for benefit for the beta blocker is not strong. It is observational data. But that said, I typically, and I know Dr. Tweed does too, we generally use beta blockers, and if patients are doing well after a year, we like to continue them. Although the evidence, if somebody says, but I feel lousy on them, I can't take it, my blood pressure or my heart rate's too low, the evidence isn't strong enough to say, you have to be on it. There are others. I think the really important thing is that we control blood pressure. That's probably, and it may be that regardless of the medication we use, metoprolol or amlodipine or whatever we use to lower blood pressure is probably just as good. Don't know that. So we really want to treat elevated blood pressure and aim for normal. So normal is less than 120/80. A lot of confusion. It is a strong guideline for us cardiologists if somebody has a heart attack that we give them a statin. Okay? Because, and I'm a statin fan. Statins have clear data that if you have an atherosclerosis, if you have a plaque rupture, and I put you on a statin, I am going to strongly reduce the risk you're going to have another heart attack. First or second. There's no evidence that this influences your outcome for SCAD. So our approach is not routine statin use, but statin use if you have very high cholesterol, because I'm a preventive cardiologist and I want to prevent atherosclerosis too, right? So if you've got both. But I think that's a combination. The automatic prescription of statins isn't something that we necessarily recommend. And then there's no other really SCAD drugs. If somebody has heart failure, they got a stent, we do that for them. Now, the thing that is sometimes misunderstood, and we may change this recommendation at some point, but we're talking about the exogenous hormones. So that could be oral or patch contraceptives or postmenopausal hormone. SCAD happens 90% in women. There's a blip in vulnerability around the time of giving birth. It has to be something that is sex or hormonal, that is. We don't fully understand it. So it's not that we know that those things are definitely harmful or dangerous or increased risk of SCAD, but we don't know, and if somebody doesn't really need those medications, we prefer to not take them. And if they do, then we like to have that conversation. I mean, I know you talk to patients a lot about whether it's appropriate contraception or postmenopausal hormone, and what we kind of don't do is, hey, I just, I'm having some really mild hot flashes, or I read that estrogen was good, but I'm fine, I'm not having any symptoms. We would just usually encourage that woman to see if they can get through menopause without extra hormones.
Yes, and a lot for all these medications generally are a nuanced conversation, patient by patient, because there are lots of nuances for any of these, even when it comes to the beta blocker, whether or not someone's ejection fraction is low or what have you. So again, these are some general overviews, kind of in the context of SCAD and concern for recurrence, but when it comes to the individual patients, it still requires a lot of nuanced consideration.
And I think because migraines and SCAD there's a big overlap, a number of individuals are on triptan medications like Imitrex. Those are vasoconstrictors, and after a heart attack of any kind, we would advise stopping that in addition to SCAD. But because the prevalence of migraines is higher in the SCAD population. Now the good thing compared to even 5 years ago is there's a whole lot of heart-safe migraine medication. So I spend a lot of time telling you, go back to your headache neurologist and talk about what's available now, because maybe you don't need those medications. And the other class of medications that we have are some of the stimulant ADHD drug medications, would also, in some people, have some risk. I'll let you talk about kind of what we...
Yes, so I imagine a lot of you are familiar with the fact that fibromuscular dysplasia and SCAD are very closely related, and a lot of SCAD patients also then find, if they're imaged for it, that they have fibromuscular dysplasia. And this is something that was first observed back in 2012 or so. It took us by surprise. The group in Canada also noted it, so for both ends. And it is a topic of conversation. There's probably a spectrum of disease, and there's discussion about whether SCAD represents a component of FMD in the arteries. We've looked at this specifically, but when we look at FMD in SCAD patients, it's up to 40 to 80%. It really relates to the artery wall being abnormal, and as a result, there's increased risk for aneurysms and dissections. Back in the old days, they primarily diagnosed it via pathology, like an artery sample, say during a renal artery bypass, but now it's primarily by imaging, usually a CT or MR with contrast, so CTA or MRI of the arteries. Several subtypes exist, but the most common that's been associated with SCAD is referred to as multifocal fibromuscular dysplasia, where the middle layer of the artery is affected, and there's alternating fibroplasia changes. So that's where you get that string of beads appearance. It's not thought to be due to plaque or inflammation, but there's a lot of research and interest in trying to understand why it occurs as well. And even from the genetics perspective, there's likely overlap with both SCAD and FMD. There are associated conditions like high blood pressure, headache, migraine, pulsatile tinnitus, things that we commonly see in SCAD patients as well. So when we think about FMD for SCAD patients, we think about the importance of the clinical history. It's recommended in the AHA statement, but we do this routinely in our clinic, at least a one-time imaging of the most important arteries, which from our perspective, based on our work, is head, neck, abdomen, and pelvis. Depending on the patient, sometimes the chest, but the echo sometimes will reveal that least in the aorta as well. And then sometimes we, again, patient by patient, and there's no strict guideline on this, but depending on the findings, that will guide the future imaging. For some patients, we say, okay, 2 years we'll relook, others maybe 5 to 8 years. The key, and Dr. Hayes really highlights this, is the indication is not to rule out FMD. It's more so to make sure there isn't a large aneurysm or something that should be closely followed, headed forward. But when it comes to counseling patients, I think you and I both agree, we've noted that it's important to counsel patients similarly when it comes to lifestyle and blood pressure management and so forth, in part because if a patient's had a SCAD, that already tells us that the arteries are vulnerable, and we discussed situations where a patient maybe doesn't have clear fibromuscular dysplasia and their neck, but then did something and then later had a dissection. So that's affected how we've guided patients. I don't know if you have further thoughts on that, Dr. Hayes.
A couple things. One thing that Dr. Tweed and I decided to do within the past year or so is we realized we've been seeing patients in SCAD clinic for over a decade. And some of them saw us one time, 8 or 9 years ago, and maybe they're going to come back for a checkup or they want to know what's new. And we said, well, do we repeat that CT angiogram? Do we take a relook? There really isn't much guidance. So we said, sort of arbitrarily said, well, if they haven't been there in 5 years, they haven't had imaging, let's look again. And I would estimate that there's probably about 30 or 40 patients that we've re-imaged that had not had imaging for a number of years. And out of that 30 or 40, there's about 5 or 6 of them that had normal arteries, and now this year, or within the past 18 months, had very, very mild FMD seen. And whether that is a change, or whether it's, I know for a fact that our imaging techniques have advanced massively in the past 5 to 10 years. So whether it was there, we couldn't see it. And that's kind of why I say I don't think current techniques can say, hey, good news, you do not have fibromuscular dysplasia. I think what we can say is you don't have an aneurysm, you don't have a dissection, you don't have something we need to follow long term, but we want to see you back. And that's kind of the approach that we're taking at this point, is a watch and see. But even individuals who have normal scan, we're recommending, I'm currently at about 5 years, come back, because I think the other thing is we have a few patients who we said, let's rule out FMD. And we did this scan, normal. And then for whatever reason, they had some imaging of their legs or arms, which are not included in this, and they had classic FMD. And we're not going to go look at every artery in somebody's body. Maybe someday, Star Trek, the whole thing, we'll be able to do that. But right now, that would mean a lot of dye, that would mean a lot of radiation. We're just looking at the important arteries. So I say that because this is sort of a moving target, and I don't want people who've had a SCAD to say, hey, great news, Mayo Clinic didn't find anything, I guess I'm free. I wish I could say that, but I think we've still got some more work, and I don't want to tell somebody, oh, you have a one-time normal scan, you're good for the next 4 years.
The other thing I'll add is, even for those who do have a diagnosis of fibromuscular dysplasia, is for those who've had serial imaging, it's very unlikely to have significant interval changes. It's more often than not very boring. Even some of those aneurysms stay exactly the same every couple of years when it's re-looked at, or every year. And that's a good thing. But I think that is also a source of reassurance.
Yeah. Well, if you
Yes, so we have also very much interest in pregnancy-associated SCAD, and that's a topic near and dear to both of our hearts. And there is concern about that because SCAD has been associated with pregnancy, most often occurring in the postpartum stage, and it has been noted to be more severe. So more severe types of heart attacks, what we call a STEMI, which means more likely than not the artery is completely occluded, causing the ECG to have very dramatic changes, cardiogenic shock, multiple vessels involved, and there's a whole list there. But it really drives our attention because, as you might imagine, there's a fair number of patients who've had SCAD who are of childbearing age and may be interested in having future pregnancies. And we are concerned about the risk of pregnancy. So currently, when it comes to a reproductive discussion, we encourage patients to not proceed with future pregnancies, and we talk about non-hormonal contraception, with kind of the exception of levonorgestrel IUDs, where the amount of exposure to hormones is quite minimal, and patients have tolerated that approach well. And the challenge is, what if I become pregnant? So some patients either become pregnant unintentionally or say, this is really important from the values of myself or my partner. And what we have found when we've looked at that, as well as most women with history of SCAD tolerate pregnancy and lactation of SCAD without SCAD recurrence. However, about 8 to 12% will still have a recurrent SCAD, and because of the hormonal basis, that's certainly concerning, especially since we've just showed you a slide that shows that when it's associated with pregnancy, it's more severe. So we continue at Mayo Clinic to discourage pregnancy after SCAD, but we do have patients, you're adults, free will, you have to choose, align your values and live your life accordingly. So if someone is considering pregnancy, we highly recommend and have done preconceptual counseling, ideally with a partner or key family members, review medications, review cardiac function, involve our colleagues in maternal fetal medicine and other specialties as relevant. And then certainly a cardio-OB team is a must. So that means getting all the appropriate specialists on a team to care for that patient. And there is more to that, but I think we went into enough detail for right now. These are some of the articles, though, about mental health, because that is also an important topic that we've spent a bit of time looking into and continue to work on both at Mayo Clinic, but in collaboration with others.
Yeah. So this is sort of the part of the talk where we talk about the real things that you've heard from patients, like what are the real questions, what are the losses, what are the things that after SCAD, 10 years ago we didn't have a lot of answers, and I think we have more answers, if nothing else, to affirm that these are things that are very common among a large group of SCAD patients. So, uterine bleeding. So, if we have a woman and we put a stent in her, and then we put her on aspirin and another antiplatelet medication of some type, many of them will get significant uterine bleeding. I will tell you, a lot of cardiologists that kind of just go, they don't take care of a lot of premenopausal women. Most of their patients are older, and they might not even really, it may not click with them when their patient goes in and says, like, I'm anemic because my periods are so heavy. So we know that happens, and so really having conversations if that is an issue, and our conversations are different whether somebody wants to preserve fertility versus, my family is complete, I just don't like all of this, and I need to be on these drugs for at least a year. We talked about fibromuscular dysplasia, we've talked about migraines, to talk about the psychosocial burden, the importance of cardiac rehab, the importance of recognizing that it's normal to be sad, and it may even be common to be depressed or be anxious after having a heart attack, but it is not something that we would want people to suffer from for a long time, and then seeking help and recognizing that that is a common problem, particularly among younger women with heart attack. And then I think acknowledging the loss that people think. You get loss of sense of health. Loss if you were planning to have a larger family or start a family. And the grief and the loss that accompanies that, I think is really important. And we're exploring that, but I think just talking to our own colleagues about how this is, it's no worse for somebody who's 80 who has a heart attack, but a lot of people who are 80 have heart attacks, right? People who are 30 or 40, there aren't a lot of them. And often finding that common, and even somebody who understands the kind of feelings is a challenge, and that's what we spend a lot of time trying to do. Talk briefly about, we indicated that chest pain after SCAD is very common, and it's all sorts of things. We think it's part of the healing artery. We think it may be a little bit of coronary irritation and spasm. We think that some people just are very hyper aware of everything. That's a thing. Like if you have a really bad break of your femur and the nurses come in every 15 minutes and ask how your pain is, you're going to be trained to be better attuned to your body. Some of it's that. But just because it's common does not mean that it's normal. And I think what we advocate for is let's try to figure out what it is. Is it something we need to do another angiogram, a stress test, or something that could be diagnosing? Can we reassure her? Do we need to treat her with medicine? Do we need to do something else? I think the other thing we talked about is menstrual cycle. Menstrual cycle variations in cardiac symptoms has been reported for 40 or 50 years. Different levels in arrhythmias, but also different levels of chest pain. And a lot of patients report that. And there are ways to acknowledge that that's a real thing, as well as sometimes to treat it. So these are some of the things that we do, CTs and others when we are treating them. So let's talk about what we want you to do after SCAD. Well, one, we want you to be part of rehab. And I know some of you have had amazing rehab experiences, others weren't referred at all. And others maybe felt a little prohibited in doing things, like they treated you like kids love, or they didn't realize you're the 35-year-old, right? And I was running marathons last year, and you're having me walk at 3.2 miles per hour for 20 minutes, and that's it. I think that's where we really need to raise the level of skill set for cardiac rehab professionals, but realizing that many in smaller towns or in smaller hospitals don't have a lot of experience in customizing across a large, they maybe only see post-bypass patients. But I think maybe you don't need cardiac rehab to gain physical strength back after. But I can tell you, talking to many, many SCAD patients, that gaining that confidence in your body and having you feel something, and have the rehab professionals say, hey, everything's good, keep walking. That kind of early feedback is amazing. And we know that women are far less likely, with any age, far less likely to be referred to cardiac rehab. So I think it's important that you advocate for others in that regard, just so important. In terms of what we want you to do, 30 to 40 minutes of physical activity, just like anybody else, moderate physical activity. Where the conversation is sometimes challenging is in somebody who was training for a marathon, or they were literally at a boot camp, or an exercise boot camp, like a CrossFit. Those are things because of the association of high intensity exercise. With the onset of SCAD, we advise against. We also acknowledge that for some of those individuals who were doing high levels of exercise, that was their main source of stress relief. So we say, hey, don't go for that 20-mile run. And I have just taken, and now that individual not only has stress because they just had a heart attack, but now I've taken away something. And I think that those are the important kinds of conversations that we have to have. But I also have many, many patients who were those 20-mile runners who have found great joy and have been able to manage their stress by getting involved in yoga and taking long walks in nature and other things. But I do think having those conversations, and some of you may have had to give up something that they felt was really important. And sometimes because of the lifting, we don't like people to lift things that require them to hold their breath and bear down. For some people, that's kind of easy to do. Like, okay, I won't move my furniture anymore around my house, my living room furniture. But for others, it's a part of their job requirement, right? So having to have conversations about that. Anything else about physical activity? We've got some other things that, so this is, I think it's a nice graphic. It was one that was, you see who the lead author was, Dr. Tweet, but kind of talking about, yes, we recommend cardiac rehab in moderate intensity, endurance aerobic yoga poses with extreme head and neck. I have patients ask, I was told I can't do yoga. Yoga is all about breathing. It is not about straining. Yoga is great, but there are certain poses that they're really hard for you as to practice. Maybe you should avoid those, right? And then we do want to, I do have one patient who literally was at boot camp and she said it was the hardest boot camp and quote, 2 people had already dropped out, but she wasn't going to be one of those because she was one of the few women at the boot camp.
So Dr. Hayes kind of mentioned something. First of all, notice who the lead author is.
That's what I said.
No, well, I meant the final author, the senior author, as we would call it, Dr. Hayes. But the other thing that excited me about this particular article is there isn't much out on this topic because it's very difficult to study and there really isn't much out there. So when we submitted this, we originally put it in, I think it's a review, and we were told to change it to a viewpoint, which is like an opinion piece, so to speak. But also we collaborated with Dr. Jeff Olin, who is one of the leaders of the USFMU registry and a good friend and colleague and collaborator. We collaborated with Dr. Bonikowski, who leads our cardiac rehab at Mayo Clinic and has a keen interest in trying to help guide patients through recovery after SCAD. And then also across the pond with Dr. Adam, who leads a lot of the SCAD and FMD research in the UK and in Europe. And when we came together to do this, it was essentially, hey, there's nothing out there, there's minimal evidence, but what do we tell our patients? And what can we put together, even if that is a viewpoint, to help guide other clinicians? So that's where this came from. All right, so also post-SCAD advice, you know, some of this is kind of that consensus, like, okay, there's not much data, but we care for a lot of these patients, and some of it is incorporating the component of common sense as well, or experience. But some of the important things we talk about is good blood pressure control. So we aim for normal, low, and through the years I've aimed for more low than high, just in part because of experience. So in my notes and what I tell patients is less than 120 over 80, and I use medications if we need to. So long as you're not making someone feel really sick, really lightheaded, or having a lot of side effects as a result. We avoid triptans, as already discussed, or engage migraine specialists if we need to. We talked a bit about the mental health piece and engaging psychological support, and we now at Mayo have a cardiac-focused psychologist who works, or psychiatrist who works with us, and then also consider the genetics consultation to look for arterial panels. And I think we have some slides on that.
So I'll pull those up, and I think one of the things that, yes, there have been some families that have had SCAD, like a mother, daughter, aunt, niece, brother, sister. It is very, very uncommon. It makes up far less than 1% of our registry. So that's one thing. Two, there is no SCAD gene and there's no FMD gene. So when we talk about genetics, we're really talking about excluding another genetic defect or mutation that makes somebody more vulnerable to dissections in general. Right? That's really what we're looking for. I think that the more nuanced that we have been involved with the DNA samples that we have collected and collaborated internationally does appear that there are some risk markers. So these are variants, so not mutations, they are a variant. Because, often you'll have two different types of, you'll have a gene and it will be displayed as one or two different types. So these are more common in patients with SCAD or FMD, but they're generally common in the general population. So it's not like you can say, oh, you have that, so we're going to test for that. I think our hopes would be that at some point, maybe in the 5 years, we will be able to gather these 14, 16 different variants, risk variants, test for all of them, and understand which ones are the riskiest, which ones, how can we say, well, you're at higher risk or lower risk for recurrence. Would be really helpful for patients. It would be helpful for our counseling. So that's really where the future is. Only about 4% of patients, if we test for the current gene panels that are available for either connective tissue disorders or aortic disease, of SCAD patients are going to test for one of those genes. So I think it's important to know it's incredibly interesting and important, but it's not something that's going to be available clinically now or in the near term. Anything else on that? No. So I often get asked, are there supplements that I should take? Is there anything I should eat or not? Eat a healthy, heart-healthy diet. We have not found anything from a dietary standpoint that either makes it more likely or less likely you're going to have a SCAD. Bottom line. Supplements, managing menopause. Again, we will talk about that. That's a very individualized thing, but if we can avoid hormones, that's really what we're hoping to do. I think last year at this one we talked about sex after SCAD. You can do it. I won't go into detail.
We did go into detail last year.
And there was a very specific question last year. Which I will answer again, but yes. So I'm going to let you take it further.
So transitioning to the evolution of the Mayo Clinic SCAD research program, I will mention that my 5 children were at one of the dinner tables last year too.
That's why they're not here tonight.
That's why she answered it. So we'll start at the top and talk about patient-initiated research, which is what this is, right? Patients came to us and really inspired us and continue to inspire us. This has been an ongoing thing when, I think if Dr. Hayes and I start feeling tired, then we think of all of you, like, well, we can't stop. We have to keep doing this. And we mentioned that pilot study, and then it transitioned to recruitment, and suddenly we're getting into scientific discovery and collaborations, both here in the US but outside of the US as well, which is, then increases awareness, both within the community, but also medical practice in the research field, changes in practice, and then that leads to prospective studies. And I'm just going to make a comment. When I was a resident submitting abstracts on SCAD, the feedback would be, it's not high-yield enough, or we don't see it enough, it's not relevant enough, so I'd send it to these big conferences, and it was not always accepted. Fast forward now, these big scientific conferences like the American Heart Association or American College of Cardiology, they're inviting us to come talk about SCAD at SCAD-specific panels. So within a decade, we've seen a huge transition and change in focus. All right, so these are some of the Mayo updates. So this is, I'm just going to talk briefly about the prospective registry, which you've heard a lot about, and a lot of you already either participate or know about. We have over 1,600 patients that are confirmed. We have imaging, questionnaires, narratives, some follow-up questionnaires there, here and there. No problem. One thing I'll mention is we have a phenomenal medical student working with us. We put a lot of time and energy into a follow-up questionnaire that also includes breast cancer-focused questions. It is IRB approved now. We're just working through some of the kinks, but we hope to send it out to our current registry participants. So if you're on the registry, keep a lookout. If you see any issues with it, please don't hesitate to tell us. I would prefer to know, but we've spent a lot of time, literally almost a whole year, reviewing it, vetting it, improving it, making sure our board review is okay with it. This is an article that came out from a questionnaire that we had sent early in the pandemic to learn about COVID and SCAD. And first off, there's a medical student who wasn't sure quite where she was going to.
She's the urologist.
She's the urologist now. She matched for urology. But, well, she will be one of the most in-tune urologists when it comes to SCAD. So we did this pandemic survey. We invited a little over 1,300. We had over 700 respondents, which is actually phenomenal for survey group-based research. A large proportion were women. And some of the things we found, and granted, this was early in the pandemic, but it was found that symptoms of COVID actually early in the pandemic was minimal. But the things we really were concerned about were risk of hospitalizations, adverse cardiac events is very low in our respondent group. And granted, there's some bias, but also we found that yes, there were some moderate level anxiety symptoms and depression symptoms, but those were similar prevalence at times of when we've surveyed people in the past. And then interestingly, but not surprisingly, the respondents reported at least monthly chest pain, and that was about half of individuals. So again, brought our attention to, oh my goodness, a lot of people are still suffering after their SCAD with recurrent symptoms, whether or not they're cardiac, hard to know in some individuals compared to others. But that was some of the key points from this paper. This is another paper we were proud to put out. There were patients who came to Mayo Clinic and agreed to be in a prospective echo study where we used novel imaging techniques. We have probably 3 or 4 papers going with that, but this is one of the recent papers that we put out looking at the echo and looking at coronary tortuosity to try to determine if there's certain features on echo, including looking at strain and some other measures that were more or less associated with tortuosity in patients who had SCAD. We found that actually those measures were similar between the two, but certainly this is one of the largest reports looking at echo parameters, including novel imaging techniques out there. And some findings that will help direct future research and hypotheses was all of the patients who had a larger aorta, even if it was measured within normal range, had coronary tortuosity. And it was also coronary tortuosity specifically was associated with fibromuscular dysplasia and also older age, which then brings up a few hypotheses about, well, what goes on with the natural history of fibromuscular dysplasia and how often should we be imaging patients, especially if they had SCAD at a young age. This is in, Dr. Hayes, please weigh in. I get a little enthusiastic when we start talking.
This is such a cool picture, but it's really esoteric. But isn't it cool that she's doing this work? That's what I would say.
But not alone. It's with a lot of great people and wonderful thought leaders arteries. But so just tell me to put the brakes in if I get too far and excited about this. But this is a paper that also came out from our group, really looking and proposing, and this is Dr. Rajiv Gulati's kind of thoughts that matriculated, and we worked together to present this as a group, that there is probably a subset of SCAD patients where you might argue that the disruption from something like a stress cardiomyopathy contributed to the SCAD related to changes like a hinge point in how the muscle moves where the coronary artery is. And there was a case where we presented where we showed that the SCAD occurred right at that hinge point, and this patient who likely had both SCAD and stress cardiomyopathy. And that is really important, one, for trying to understand why SCAD occurs, but also understanding in some patients, there's a lot of debate right now, is stress cardiomyopathy part of SCAD or not? Is one misdiagnosed as the other? And so from a scientific perspective, it's really exciting trying to understand why SCAD occurs.
And when we talk about the term mechanistic, that really is kind of where we're headed. Because what is the most common question that I get when I see a patient in the office is, what caused this? Why did this happen to me? And I can say, oh, well, you have weak arteries because you have fibromuscular dysplasia, but why did it happen to me and why did it happen to me that day? And I think that's really, it is not going to be a straightforward answer, but that really is that next step of what we're doing. And Dr. Tweed's doing a lot of that work.
And you give me too much credit, as a lot of individuals at Mayo Clinic, including yourself, doing this. But I just get excited about talking about it. So this is a project that Dr. Gulati has been doing for a couple of years now when acute patients come through the ER collecting bloods, both in patients who have heart attack from SCAD but other causes, and he's doing some novel looking at proteomics and some other biomarkers to, again, better understand what might make a SCAD patient different, why is it occurring, what should we consider differently when it comes to treatment specific to SCAD compared to other types of heart attacks. No problem. We don't have to stay on this one long, but this is an echo study that we have collected all the data for over the course of a couple of years. It's been going on for a while. That actually led to that paper that I presented to you earlier. There's a couple more in the works, and it's also serving as preliminary data for one of our grant proposals. And then, I was fortunate enough to receive a dedicated NIH funding at K23. This finished just the second of 5 funded years for this. And this is, again, just highlighting the importance of collaboration. So when Dr. Hayes and I have talked many times about how do we look more at mechanisms or trying to understand why SCAD occurs in order to be better at knowing how to prevent it or how to better recognize it before it happens, we realize that looking at the vascular and autonomic function of patients is very helpful. And fortunately, there are several colleagues at Mayo Clinic who do this work and have been excited about collaborating and have put their own funding to support this work in addition to what I have received. And it's based on a theoretical framework there, but these are some of the pieces of the great collaborators who've been working with us on this. And as of this year, some of our early work has been already presented with 2 abstracts presented at the American Physiological Society this spring. And then this is Dr. Grimaldo, who just finished medical school, and I'm hopeful she'll become a cardiologist. She went and matched in internal medicine at Tufts, who has done a lot of exceptional work looking more at the pregnancy-associated SCAD part. And then this is Dr. Ashley Battenberg, who is a medical student now working with us. I'm very proud to say that she wrote a very compelling paper and won a very competitive alpha-omega alpha research fellowship to support her research in collaboration with our registry. So we're working with our registry to look specific at breast cancer and SCAD patients in collaboration with our colleagues in the breast cancer clinic at Mayo Clinic as well as Women's Health Clinic. And she presented her preliminary work just this June, and she is also the one who's dedicated a lot of effort into preparing a survey. So that's the survey we told you about.
Well, here's the websites, here's some resources, most of them you know. We've got SCAD researching, we've got our website, we've got the wonderful Facebook page that many of you, probably all of you, are on, that is administrated we're going to stop now. We would say, again, thank you. Much of this work would not have happened without the support, both funding, but also just the impetus and the giving of the patients who have either come to our clinic, volunteered to be a subject, or just said this is important work because it's us, and that does keep us going. And so, thank you. We will, if there's time, we will take questions. I will look to Ellen if there is, and I know we've got some online folks, but otherwise we will see you at the skedaddle tomorrow.
It looked like I'm trying to bring a plane in.
I know. I love that picture.
Any questions in the audience here?
When we get together, so it's got one line.
I got a question, Viv. Is there a way to detect a SCAD without using the imaging contrast? The reason I bring it up is she actually had 2 SCADs last year. First one was a very tiny one that got her sent, I think, dragged to the hospital because I dragged her there because she had heart attack symptoms and they kept her. And then did a catheterization exam the next day. At first they were fine, and then she had a massive, a little dissection became a massive dissection. And her cardiologist said, well, that was probably because they stuff they injected into her artery so they could do the imaging. And he said it was kind of catch-22. They would have.
Yeah, I think this is a great question, and it's one we'd like to clarify because really the only way that you can diagnose a SCAD currently, 2024, is with imaging. Because otherwise it's just a heart attack that we don't know the cause of. So I think we really advocate for, and I will tell you, I am seeing a trend, we're both seeing a trend of patients maybe who've had a SCAD before, and they go in and they have chest pain, they have heart attack symptoms, they have elevated troponins, they've clearly had another heart attack, and they get no imaging. They don't get a CT coronary angiogram, they don't get an MRI, they don't get a coronary angiogram. We're very concerned about that because, for 2 things, maybe they're saying, oh, it's probably another SCAD, you'll be fine. Well, what if the last SCAD was a really distal vessel that did not cause much problem, and this time it's in a vessel that could cause a lot of problems. And these people are sometimes being sent out the next day from the hospital without any imaging. I think that actually should not be done. So to answer your question, we are in a rock and a hard place because in order to make the diagnosis, we're either going to have to do an invasive coronary angiogram or we're going to need to do a CT coronary angiogram. And that technique is better than it was even 2 or 3 years ago, but it does not show the arteries very well that are farther out in the arterial tree. It's basically a CT, she's an expert in CT, but basically think about the heart, it's squeezing and twisting, right? And so it's a reconstructed image, and all of the vessels that are at the tip of the heart where it is squeezing the hardest and twisting the most, they're blurry. So I would just say it's a balance, but I think too much fear has been put into sometimes patients or cardiologists said, oh, it's probably a SCAD, I'm not even going to do an angiogram. And we feel like, well, it could have been something else this time. Maybe if they're 65 now, maybe they've developed plaque and they really need a stent. We have cases where somebody assumed it's just another SCAD or it is a SCAD, and they went on and suffered for months because no one stented that artery. It wasn't a SCAD, it was plaque. So I would just say the answer is no, we can't do it without imaging. We can diagnose it as a probable heart attack, but not the cause. I know you're pretty passionate about this as well.
You covered it very well. And the CT is tricky, as mentioned, but that perhaps could be argued as a less dangerous, invasive approach, but because the contrast is given through the vein instead of into the artery directly. But there are many other challenges, including difficulties both with the small vessels, as mentioned, but even distinguishing at this point plaque versus hematoma. So really knowing the cause on CT. And there's a lot of interest in ongoing research efforts, both by ourselves and others, to better define that. So I think both Dr. Hayes and I would agree in the next 5 to 10 years that landscape is going to completely change because there's a lot of effort and interest in it.
I have a question online. How can one go about getting your immediate immediate doctors to want to help. And for all the patients that have no specialists, like in my case, in Memphis, Tennessee, it's not possible to see specialists virtually. How do you fill the void?
Well, one way I get excited about filling the void is teaching the next generation. So we have a lot of involvement both with teaching in the conferences, classrooms, medical students, one-on-one research. One of our papers, the one about autoimmune disease, was because I gave a talk to all the residents at Mayo Clinic, and a resident came up to me and said, I'm interested in rheumatology. Have you looked at autoimmune disease? And I said, no. She's like, can I do it? I said, sure. And that's where that paper came from. So that's one way. I think maybe from a practical standpoint.
Yeah, I think right now, the SCAD research community is relatively small. It is, when somebody says, do you have a SCAD expert in X city? And I can say, I can list about 8 cities where I would say there's really somebody who's committed to learning, studying, and treating SCAD patients. What I recommend to people from a practical standpoint is getting a good cardiologist who listens to you, who takes you seriously, and is open to learning and has not decided that they've learned everything that they need to know and that they know everything. I have great humility. I have had a long career, and there are things that I told patients 20 or 30 years ago that are just wrong. I know that now. And I can say that because, gosh, I did a disservice, because now we have data that says something else. So when somebody says, I don't have a SCAD specialist in my community, I say, virtually no one does. Like, if you live in Rochester, Minnesota, if you live in Palo Alto, if you live in, there's a few. What I would encourage people to do is find somebody who listens to them, who really is going to continue to ask questions. The best physician you have is somebody who says, I really believe in second opinions, or I'm going to pick up the phone and ask someone else because I don't know. I will just say that that's the kind of doctor of whatever specialty I would want. I don't necessarily need to have the one that is a specialist in my disease, but I would like to have access to that through somebody who trusts and knows me and my values. And that's kind of the answer that I give, because I think it's probably unrealistic that every little community and every single cardiologist is going to be an expert on SCAD at this point, because it's just too much unknown and to know.
Any other questions for the house here? Come on, guys, kind of have questions. Yeah, see, I knew.
I wanted to ask about aspirin, if that's still recommended as something that you should take.
Indefinitely. Okay, first I want to start with, if you get a stent, antiplatelet agents are recommended indefinitely. Okay, I never say for life, because until something's better. But if you received at the time, and I think that's separate, because I think you have to start with that. If you have another reason to be on an antiplatelet agent, and if you got a stent, that would be one, and that would be indefinite. But most patients who had a SCAD who did not get a stent are put on aspirin. And I think both Dr. Tweed and I are having individualized conversations with individuals about, do you need to be on it still? To me, it doesn't make a whole lot of sense, because, as we said, this is not a clotting event, it is a bleeding event. But I would say then my colleagues who specialize in fibromuscular dysplasia, they recommend aspirin for everyone with no evidence. If you really push them, they said there's not one paper that says aspirin prevents anything. So I don't want patients to feel that if they're going to an FMD doctor who said you have to be on aspirin, I've backed off a bit on that. I think in the first year, it's probably reasonable, particularly if there's any doubt in the diagnosis, because if I'm at all on the fence, was this a SCAD, or maybe I can't tell by the angiogram, I want them on aspirin, because I don't want to be withholding treatment from someone who might not have. So I think that's not your case, but why someone, I might still be saying you should be on aspirin, because I want to make sure you're protected from a blood clot. But I think that's something that, even if you've been seen by us, you were seen by one of us 7 or 8 years ago, or even 5 years ago, I think we're having different conversations now, because the evidence just isn't strong for the benefits of aspirin. And for sure, neither of us would say dual antiplatelet therapy. If you have a regular type of heart attack or a bypass, you're going to go out for a year on 2 antiplatelet therapies. So that would be aspirin plus clopidogrel or ticagrelor, one of those medications. We stop those when we see them campus if they didn't get a stent. Yeah.
And that was based on one retrospective study, so there's slowly some data coming out. There's not much. There's a group in Spain that's prospectively looking at treatment with antiplatelet therapy. There's a lot of talkings with ourselves and others about how to do that in the States as well. So there will be more to come and more guidance. And it is a case-by-case basis. You know, if you have a patient who has other reasons to be on aspirin, keep them on aspirin. If you have a patient who maybe has a lot of aneurysmal disease with their fibromuscular dysplasia, that may be one I want to keep on aspirin. But if it's really mild and we're not worried about these theoretical blood clots, and they're 5 years out and they didn't have a stent, and they're having lots of heavy bleeding, that could be a circumstance where it just doesn't make sense, and there's no data to tell us that it's mandatory.
I saw someone else. Yeah.
Kind of similar question, but what's the current guidance specifically for SCAD patients on NSAIDs and also like cold medicine decongestants?
I can speak that. So, NSAIDs, which is like ibuprofen, right? All of those has been, as a class, has been associated with an increased risk of heart attack and stroke. Okay, so I'm just going to say that. Not SCAD. The mechanism is that one of the mechanisms is it can increase the stickiness of the blood. It also decreases blood flow to the kidney, raising blood pressure. So most of the increased risk that has been associated has been more the atherosclerosis. No definite association with SCAD, but I can't say there's not an association with SCAD. I think when we talk about patients with SCAD maybe having more blood pressure problems, it's not something we would want them to take every day. So what I tell patients who ask me that, and I get the question a lot, is I say, if you sprain your ankle and you need some pain relief for a few days with an anti-inflammatory, I don't have a problem with that, for a SCAD patient, assuming they're uncomplicated, not having. But I would not want any of my cardiac patients prescribed it on a daily basis at high doses over a long period of time, because I do think that is where the data would suggest they probably isn't good. And I think you differ anyway with that. I think in terms of the cold medications, the things we want to avoid are those, and again, this isn't specific to SCAD, it's more heart patients and high blood pressure patients, is the vasoconstrictors, which is often the pseudoephedrine. So if it has a D after it, it probably is something that, which is often the decongestion, is probably the thing you want to avoid. So Claritin, for instance, fine. It's a non-sedating antihistamine. Claritin D, it's not a hard stop, but if you can get by with something without the vasoconstrictor, either the pseudoephedrine, definitely recommend. Anything else to add? Yeah.
Okay, another question from online. If you've had a higher heart rate or have a tendency for your heart rate to go high, especially with walking or any exercise, really, is there anything you need to be aware of or do differently? Should you continue cardiac rehab if your heart rate goes higher than, let's say, 140s to 160s?
Okay. This is my pet peeve. It's people who are arbitrarily given a heart rate, like in rehab or anything else, don't go over. Our cardiac rehab doesn't. We don't give heart rate limits or ranges, and there isn't any logical. The only time we would say somebody, I have patients, and it's not SCAD patients. It's a patient who has lots of blockages. We've done our best with bypass and stents, but they still occasionally get angina. We've done a stress test, and when their heart rate goes over 130, their heart is on the heart rate limit. I think particularly for young people, often those limits are set up for somebody who's in their 70s. So they say don't go over 120. But a normal 35, 40-year-old, when they do moderate exercise, their heart rate's going to be in the 130 to 140s. And then that makes the patient think they're going to die, right? I mean, oh my gosh. So to the answer of it depends on age. I don't know the age or what else is going on. So I don't want to give individual advice to this person. But if you have been given by particularly a rehab specialist an arbitrary heart rate limit, that means, and I have patients who say, well, they told me I shouldn't go over 120, but that means I can only walk a block at slow pace because I'm 30 and my heart rate goes up and I'm out of shape. So I would just say, ask some of the questions about what the rationale is, because some of them are just sort of protocol. Yeah.
Yeah, the challenge is, protocol or arbitrary. Our group really focuses more so on perceived exertion. So
feel.
Yeah, right, moderate exertion, Borg scale kind of 12 to 14, at least on the scale that we use. Certainly I've had patients where they bring on symptoms at a heart rate lower than what they were told, but they ignore it because they're like, well, I'm not to that max heart rate. That to me is more concerning. So I like patients to listen to their body, and if we can do stress tests or do more investigations, that's fine. But we don't do so much to the heart rate. Sometimes I'll calculate someone's peak physiologic heart rate because they really are pushing me. I'm like, okay, well, let's see what it is. But generally we like to focus on perceived exertion, and that's what our rehab group does.
Yeah, and what that really means is, so we ask people, how are you feeling? You feel like this is light, moderate, moderately hard. Okay, what's your heart rate when you're at moderately hard? We want you, that looks good on you, right? That looks like about, your heart rate happens to be 130, 140. So we don't ignore heart rate, but we help people say, listen to their body, and then correlate it with something physiologic. And I think that makes more sense.
Okay, we have time for one or two more questions, or actually one question. Is there any insight here that somebody might get?
How about the new drugs that are out, like Manjaro and Zepbound and those? What are your thoughts on those and use of them?
Okay, so most of those are versions of semaglutide or others. They were initially drugs, for those who haven't heard of Wegovy or one of those drugs. They're originally for diabetes. That's how they were developed. But what they found when they used those is people lost weight and people had lower risk of cardiovascular events. Now, these are high-risk people, and the cardiovascular events were largely atherosclerotic. They were strokes and regular blood. But I have patients who have SCAD who are diabetic. I have patients with SCAD who have struggled with weight and are thinking about these. And I've had more questions, I think, in the past 2 weeks about these drugs than I had had in the prior 2 or 3 months. They're out there and they're being used. And what I've been saying with no data, and I would love to say, is I can see no reason, physiologically, what I know about the medications, that they would be harmful for SCAD. I don't know that the benefit that we have seen, because a lot of it is metabolic, that we would see a benefit for reduction of risk of SCAD, like we have seen a reduction of risk of regular heart attacks. But I think if we can help people, that does not mean that there may be some connection with SCAD. If there are new drugs, we always have to be cautious with any new class of medications and saying, oh yeah, we think they're safe or we think they're harmful, with no evidence. But at least what we know about the medications that are still new, that are being used on greater numbers, is, I don't think, if anything, the cardiovascular risk would be neutral or possibly positive.
Yeah, but the great disclaimer that it just hasn't been study specific to SCAD, so you just have to acknowledge that. I do have patients who have had SCAD who are on it many times because they have other indications, and things have been going just fine for them, but again, that's anecdotal. So we just have to be aware of the pros and cons. There is some concern that if someone goes on these medications, loses a lot of weight, and for some reason, financial or otherwise, don't tolerate the drug, they come off the medication, sometimes they regain that weight back. So that's important to realize. The other concern that I've had is, as part of the weight loss, you may lose some lean muscle mass, which does not always come back, even if you stop the drug. So really, when I have patients go on these medications, I emphasize the importance of continued healthy lifestyle, good dietary choices, regular exercise. Depending on what medication it is, we often have to watch electrolytes, and some patients tolerate these great, they lose a lot of weight, and some even come off and maintain that lower weight, others struggle with side effects or what have you. So that's, again, a bit of a conversation.
And I think we got to keep that conversation. It's in the news all the time. I will say that I don't think there is any reason to stop the drug if you have a SCAD. And I've had several patients we're doing great on it. And in fact, this is in the current guidelines for treatment of menopausal symptoms. Actually, these are indicated for women with hot flashes, particularly if they have some other factors. And I did have a patient, and she was really miserable because she had been on it and it was giving her great relief. I actually had her seen by one of our women's health menopausal medicine people who said, the answer is put her back on it. And I said, well, that's what I wanted to do, but I needed the backup for that. So I think more to come, but I would use it cautiously.
I'm cautiously optimistic.
Yeah, I am too.
Yeah, there's some evidence that suggests it's good for you.
For those of you that are online, we obviously didn't get to everybody's questions. I'll go through some of these and I'll try and meet with Dr. Hayes and Dr. Tweed to see if I can get some answers during the weekend, and we'll respond back to you online. Thank you, Dr. Hayes and Dr. Tweed. Brilliant. Okay, everybody, we'll see you tomorrow. Right? Oh, thank you. See? I had a blonde moment.
You just always blame it on your blonde.
I know. It's not natural.
The pink is natural.
Thank you very much. This is a really do appreciate it.